Hi, my name is Sarah Cosgrove. I'm an assistant professor of medicine in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine and an associate hospital epidemiologist at the Johns Hopkins Hospital. The purpose of this module is to review the role of technology in prevention of central line-associated bloodstream infections. For the rest of this presentation, I will refer to central line-associated bloodstream infections as CLABSIs. The learning objectives for this module are to review considerations for picking new technology to reduce CLABSIs, to review currently available data regarding the efficacy of several technologies in reducing CLABSIs, which include chlorhexidine bathing, chlorhexidine impregnated sponges, and antiseptic-coated catheters. Before any unit or institution rushes into adopting new technology, there are some considerations to make about whether new technology is needed and what the best new technology is for that particular institution. The first question that anyone should ask is technology needed to reduce CLABSIs in your units? A corollary to that question is, has best practice been fully adopted? The current CDC guidelines recommend consideration of new technology if CLABSI rates remain high after implementation of basic prevention strategies. This seems reasonable given that we know that the basic best practice approaches to prevention of CLABSI actually work. If these are not implemented, there's a good chance that addition of new technology on top of a system where best practice processes are not being performed is not going to help reduce CLABSI. There's also the question of whether adoption of new technology can lead to a feeling in the unit of over-reliance on the technology. So just as an example, someone in the unit may say, well, I know there was a little breach in maximal barrier precautions, but we're using an antibiotic-coated catheter, so I don't think that I need to worry about that as much as if I weren't using the antibiotic-coated catheter. This is, of course, not good logic, but is a potential side effect of bringing in new touted technologies into your ICU to reduce CLABSIs. Just to reiterate, it's important to exercise caution in implementing new technologies if rates rise after implementing best practice. The first thing you should do is go back and make sure that the units are doing what they're supposed to be doing in terms of use of best practice in placement of central lines. Some other considerations when picking new technology are, when are the CLABSIs in your ICU occurring? CLABSIs that occur less than about 10 days after placement of the line are usually associated with extraluminal contamination of the exit site. So if that's when most of your CLABSIs are occurring, you may want to look at approaches that decrease contamination of the exit site. In contrast, CLABSIs that occur greater than about 10 days after placement of the central line are often associated with intraluminal contamination via the hub or connector. And more emphasis on hub care may be indicated rather than bringing in a technology that only addresses the exit site risk of colonization. The best approach really is prevention of both extraluminal and intraluminal contamination. The other question to ask is, what are the central line use patterns in the particular ICU? If catheters are removed within 24 to 72 hours, then many of the currently available technologies may not have much use. In addition, if catheters are in place for a very long period of time, say greater than 20 days, again, new technologies that involve impregnation of antiseptics or antibiotics into central lines may not be particularly useful as they wear off over time. Another consideration is that you may need patient-level protocols to direct technologies to those at the highest risk for CLABSI. The first new technology that I'll discuss is the use of chlorhexidine bathing. This is basically using either a washcloth that has chlorhexidine in it or making a bath out of chlorhexidine solution and then bathing patients as you normally would in the ICU with regular soap and water. The theory is that if you decolonize the skin with chlorhexidine, you may decrease organisms that might contaminate the insertion site, both at the time of placement of the catheter and while the catheter is in situ. The other potential advantage of chlorhexidine bathing is that you may also reduce hub colonization if you reduce the overall microbial burden in a patient in an ICU setting. And there has been a close correlation documented between colonization of the hub and colonization of the patient's skin with similar organisms. Finally, chlorhexidine bathing of the body, which generally includes the neck down, may offer the additional advantages of decreasing rates of blood culture contamination and decreasing rates of other organisms like MRSA and VRE. In fact, chlorhexidine bathing has been associated with decreased acquisition of VRE in one institution. The evidence for the utility of chlorhexidine bathing in reducing central line associated bloodstream infections comes from a study done at one center. This study was a 52-week crossover study in 2 MICUs in which chlorhexidine washcloths versus soap and water baths were applied daily to patients. In this study, chlorhexidine bathing successfully reduced the number of primary bloodstream infections in the units where chlorhexidine bathing was employed. The rates of primary bloodstream infections were 4.1 infections per 1,000 patient days in the chlorhexidine group compared to 10.4 infections per 1,000 patient days in the soap and water group. This led to an incident difference of 6.3 and was statistically significant. The panel on the right shows the proportion of patients without a bloodstream infection on the y-axis and the length of stay in the MICU on the x-axis. The darker line is the chlorhexidine study arm, and the lighter line is the soap and water study arm. And you can see that patients who underwent chlorhexidine bathing did not develop central line associated bloodstream infection at the same rate as those patients who were bathed with traditional soap and water. The next device to discuss is the chlorhexidine impregnated sponge. This goes by the trade name Biopatch in the United States. The theory of the Biopatch is that decolonization of the catheter insertion site decreases the chance of extraluminal catheter infection. You can see a picture of what the Biopatch looks like on the right side of this slide. It's basically a little sponge-like dressing that wraps around the central line at the insertion site. Considerations for use of chlorhexidine impregnated sponges include the fact that there's a learning curve for optimal application of this device. And you may initially end up with extra manipulation of the insertion site or incorrect application, which at least at the very beginning of use of this device could have the potential to increase catheter site colonization or perhaps CLABSI. This needs to be monitored, and of course adequate training of staff must occur if the chlorhexidine impregnated sponge is brought into the unit. Another potential downside of the chlorhexidine impregnated sponge is that the insertion site of the catheter is not visible. And then finally, there's no effect on the hub when you just opt to use a chlorhexidine impregnated sponge. A very recently published randomized controlled trial compared Biopatch to standard dressings in the ICU setting. This study included central lines as well as arterial catheters, and none of the units used antiseptic or antimicrobial coated catheters during the study period. The outcome that was examined in this study was catheter-related infection. And catheter-related infection had a couple different possible definitions. The first was catheter-related bloodstream infection, in which patients had positive blood cultures, a quantitative catheter tip culture growing the same organism as in the blood culture, or if the catheter tip wasn't available, a differential time to positivity of blood cultures of greater than or equal to 2 hours, which means that the blood cultures drawn from the catheter turned positive before the peripheral blood cultures. And in addition, patients had to have no other source of infection. Patients in this study could also have what was called catheter-related clinical sepsis without bloodstream infection. So this means that the patients had negative blood cultures, but they did have fever, a positive catheter tip, pus at the line site, and no other source of infection. 1,636 catheters were investigated in this study, and the median duration of catheter insertion was 6 days. When The combined primary outcome of major catheter-related infection rate was evaluated in the two groups. Investigators noted that there were 0.6 infections per 1,000 catheter days in the chlorhexidine sponge group, compared to 1.4 infections per 1,000 catheter days in the standard dressing group. This yielded a hazard ratio of 0.39, which was statistically significant. The graph on the right shows cumulative risk of catheter-related infection on the y-axis and duration of catheter maintenance on the x-axis. The chlorhexidine dressing arm of the study is the darker line, and the control arm of the study is the lighter dotted line. You can see that patients who had chlorhexidine impregnated sponge use had a lower cumulative risk of development of major catheter-related infection. One interesting finding was that there were 8 episodes of contact dermatitis in the chlorhexidine sponge group. Although this is not a large number, it does emphasize the importance of evaluating the insertion site and the skin of patients who are being treated with chlorhexidine of any sort, whether it's chlorhexidine bathing or use of a chlorhexidine impregnated sponge or use of a chlorhexidine coated central line. Coated catheters are actually one of the original forms of technology that were developed and assessed with the hopes of bringing about decreased rates of central line associated infections. The theory of coated catheters is that they lead to a decrease in extraluminal catheter colonization and also intraluminal catheter colonization if the interior surface of the catheter is also coated. There are 4 broad groups of coated catheters that have been investigated. There are heparin plus benzalkonium bonded catheters. These have activity on the inner and outer surface and are available in the United States, although there's a general trend towards trying to stay away from heparin due to side effects associated with heparin, such as heparin-associated thrombocytopenia. There are also silver plus platinum coated catheters, and these coatings are also on the inner and outer surface, and these are available in the United States. Chlorhexidine and sulphadiazine catheters uniformly have these agents on the outside of the catheter, and a second generation version is available that has both inner and outer coating. Finally, there are catheters that have antibiotic coating on the inner and outer surface, and the antibiotics are minocycline and rifampin. Because the chlorhexidine and the minocycline and rifampin coated catheters are the most common, I'm going to limit my discussion of these catheters to those 2 varieties. I'm going to show you a variety of panels that were taken from a meta-analysis that was performed to evaluate the efficacy of coated catheters. This first panel shows the results of the meta-analysis looking specifically at the first generation chlorhexidine and sulphadiazine catheters compared to standard catheters. Just as a reminder, these are the catheters that have chlorhexidine only on the outside surface. The relative risk of developing a CLABSI when all of the studies looking at this kind of catheter were combined was 0.68, which does suggest that the use of these catheters modestly decreases your risk of CLABSI. It's important to note, though, that the upper limit of the confidence interval is 0.98, so this difference is just reaching statistical significance and not particularly robust. When looking at the 3 studies that have compared second generation chlorhexidine and sulphadiazine catheters to standard catheters, and just as a reminder, these are the catheters that have these agents on both the inside and the outside of the catheter, odds ratio was found to be 0.47 for prevention of CLABSI. However, this was not a statistically significant reduction. So there does not appear, at least statistically, to be an additional benefit of the inner coating in addition to the outer coating with chlorhexidine-coated catheters. The next panel described minocycline and rifampin coated catheters compared to standard catheters and then compared to chlorhexidine catheters. When compared to standard catheters, minocycline and rifampin catheters appear to significantly decrease the risk of CLABSI. And when compared to chlorhexidine-coated catheters, minocycline or rifampin-coated catheters also appear to reduce CLABSI more effectively than chlorhexidine-coated catheters. So what considerations should be taken when making the decision to implement the use of coated catheters? Well, heparin and minocycline rifampin coatings appear to be more effective than other coatings, but as I mentioned, there's a general trend towards not using heparin due to potential side effects of heparin. However, in the setting of use of minocycline and rifampin-coated catheters, there are limited data regarding the risk of development of minocycline or rifampin resistance, or whether use of these two antibiotics in the catheter puts patients at risk of selection of fungal organisms. Both of these things are certainly possible, and we don't know what the actual risk is in the clinical setting. Another interesting finding that was seen in a different pooled analysis of the utility of coated catheters was that when multiple studies were evaluated, the treatment effect with these coated catheters was seen in catheters that were in place for 5 to 12 days, but not for 13 to 20 days. So catheters with coating may be more useful in ICU settings where patients have kind of a mid-range duration of catheterization, so 5 to 12 days. And again, there's some discussion as to whether the antiseptic effect of these catheters kind of wanes over time. So if you have patients who have catheters in for very long periods of time, the benefit may start to disappear towards the later periods of catheterization. Another interesting finding in that pooled analysis was that the treatment effect was seen for femoral and internal jugular insertion sites, but not in studies that exclusively use the subclavian insertion sites. Now, this may be because the subclavian insertion site has much less propensity towards developing exit site colonization in the first place, in contrast to the femoral site, which is in the groin, and the internal jugular site, which is often squashed in the folds of the neck with beard growth in men in particular. So these are all questions that need further assessment, but if you have a unit where you use a lot of internal jugular central lines, because that's the favored site by the people who insert lines in that unit, it's possible that use of these coated catheters may be more beneficial than if your unit exclusively uses subclavian sites. The decision to use coated catheters really depends on local factors. As we said at the outset, you do want to determine the extent of adoption of best practice before bringing in coated catheters. And as we've discussed, you want to think about the average duration of catheterization in your unit if your plan is to just use these catheters in everyone. Or you may need to make a protocol based on the expectations of duration of catheterization at the individual patient level. So if you know there's a group of patients who tend to stay in your unit for 5 to 10 days, that may be the perfect group to target for use of coated catheters. But if you know that you have also patients who are in for 1 or 2 days, they may not need a coated catheter. It's also important to think about the usual sites of catheters in your units relative to the study that I mentioned on the previous slide. And then I, as an infectious disease physician, do have concerns about the potential of rifampin resistance when you use minocycline and rifampin-coated catheters. So you may choose not to use those kinds of catheters in patients who have endovascular hardware because if they go on to develop infection of their endovascular hardware, you may need to use rifampin in the treatment of those patients, and you would hate to have had emergence of rifampin resistance due to the use of the catheter. Other technologies that are worth discussing include antiseptic hubs, which are available. However, there's no published clinical data supporting their efficacy, as well as dressings that contain chlorhexidine. Just as an example, the Tegaderm chlorhexidine dressing, and again, there's no published clinical data supporting the efficacy of those dressings either. Obviously, having some kind of antisepsis at the hub or having chlorhexidine in the dressing makes clinical sense, for preventing hub-related infections and site-related infections, respectively, but there's just no data to guide us in knowing whether those approaches actually work. Another approach that is sometimes discussed is the use of antimicrobial lock solutions. This is where you infuse through the lumen of the catheter a certain concentration of a solution that contains antibiotics in the hopes of decreasing colonization on the interior surface of the lumen of the catheter. Because of concerns about antimicrobial resistance in particular, this approach is not recommended for routine use. So you would not want to have every single patient in your ICU having antimicrobial lock solutions in their catheters. However, it could be considered in individual patients with limited venous access and a history of recurrent CLABSI, or in patients at risk for severe sequelae of CLABSI, such as those with new prosthetic heart valves. Finally, I do want to make a comment about needleless intravenous access devices. Current recommendations regarding these devices state that you should not routinely use positive pressure needleless connectors with mechanical valves before a thorough assessment of risk, benefits, and education regarding proper use. And they go on to state that routine use of the currently marketed devices that are associated with an increased risk of CLABSI is not recommended. This is an area of some controversy. There does seem to be an increased risk of CLABSI associated with positive pressure needleless connectors, and there have been some published studies that have demonstrated this. There is some discussion as to whether problem lies with the device itself or with the way that the devices are cleaned within individual ICUs. My opinion about this is that if companies are unable to design devices that cannot be used in the construct of life in the ICU, then we probably should not be using them with regularity. It is also important to know what kind of needleless connectors are being used in your institution. And if you do see an increased rate of CLABSI, one of the things to go back and assess is, has there been a change in devices that are used for connections or infusions or items like that in your ICUs. The action items for this module are to assess compliance with best practice for CLABSI prevention in your institution. This is something that should always be done in the setting of routine practice and when you're considering new technology. If new technologies are desired in one or more ICUs in your institution, it's important to evaluate which ones are the most appropriate for your patients based on some of the data that I've described today. And finally, it's important to monitor for any unexpected effects associated with the adoption of new technologies. I hope this module provides some groundwork for understanding what technologies may be useful in your institution.